Welcome back to The Explainer. Today, we're going to unravel the fascinating science of how we actually figure out the exact right amount of an antibiotic to give a patient.
On the surface, it seems like basic math, right? You've got an infection, you take a pill, and you get better. But as we're going to see, calculating that perfect dose is way beyond simple arithmetic. It's a full-on, highly complex biological battle of timing and evolution. Because getting it right saves lives, but getting it wrong, well, that leads to treatment failure or the terrifying rise of antibiotic resistance.
Here's our roadmap for today's explainer. 1. Decoding PK and PD. 2. Understanding MIC and breakpoints. 3. The 3 PKPD indices. 4. The flaws in the formula. And 5. The future of dosing. All right, jumping right into Section 1. Decoding PK and PD, our foundational vocabulary.
The easiest way to keep these two straight is just this simple flip. Pharmacokinetics, or PK, is the story of what your body does to the medicine. It's how your system absorbs it and breaks it down. Pharmacodynamics, or PD, flips the script entirely. That's what the medicine actually does to your body, how it goes in, attacks the infection, affects your tissues, and hopefully triggers a cure.
And when we zoom in on pharmacokinetics, it really comes down to 4 distinct steps. We call this the AID-ME process. First, absorption, how the drug gets in. Second, distribution, how it travels through your tissues. Third, metabolism, how organs, like your liver, break it down. And finally, elimination, how your body clears it all out. You absolutely have to understand this whole journey before you can even think about effectively killing a bacteria.
Moving on to Section 2, Understanding MIC and breakpoints and how we measure resistance.
Okay, so the crucial thing to remember about MIC is that we're talking about a petri dish here. It tells us the absolute lowest concentration of a drug required to visibly stop a specific microbe from growing. But since it is an in vitro test, it makes MIC a property of the drug against a microbe completely isolated from a real human body's immune system or fluctuating drug levels. It's really just a static snapshot.
Building on that, we've got the ECOFIF, or epidemiological cutoff value. Think of this as a boundary line. If an MIC value falls below the ECOFIF, the bacteria is likely a normal susceptible wild type. If it's above that line, it has probably mutated and built up some resistance. But again, just like the MIC, this metric is pure microbiology. It doesn't account for what happens inside a living, breathing patient.
And that brings us to clinical breakpoints. This is the stuff doctors actually use on the hospital floor to make treatment decisions. Breakpoints bridge the gap between those isolated lab tests and reality by factoring in the patient's in vivo PK and their own immune response. If an infection hits that susceptible breakpoint category, the standard dose is highly likely to cure the patient.
Which leads us to Section 3, the 3 PKPD indices, where we merge these concepts together.
His timeline shows a really brilliant scientific journey. Right after penicillin was deployed in World War II, a visionary scientist named Harry Eagle began experimenting with animal models in the 50s. He realized, hey, it's not just the total daily dose that matters. The interval between doses is huge, even suggesting continuous IV drips might be better. Fast forward to the 1980s, and William Craig runs these landmark studies in neutropenic mice, meaning mice with no immune system, which finally gave us the actual math to predict antibacterial success.
Now check out how perfectly Craig's 3 indices map onto this one graph of drug concentration over time. First, you've got the peak, that maximum concentration, known as Cmax over MIC. Then you have the total area under the curve, the AUC over MIC, which represents total exposure. And finally, see that horizontal dotted line for the MIC? The percentage of time the drug concentration stays above that line is our third index, time above MIC. In the real world, scientists plot these indices, like the AUC to MIC ratio, directly against the actual survival of bacteria. Look at this curve. As total drug exposure ramps up along the bottom axis, the bacterial burden literally drops off a cliff on the vertical axis. What researchers are looking for here is the magic number on this curve needed to achieve a 1 or 2 log reduction in bacteria. And that's exactly what dictates the doses we use in human trials.
But here's the catch, and it's a big one. The specific index we rely on totally depends on the antibiotic class we're using. Take aminoglycosides. They need a massive initial hit and high total exposure, so they rely on the AUC over MIC ratio. Beta-lactams, like penicillin, completely different story. They don't need a huge peak. They just need to stick around. For them, it's all about maximizing the percentage of time that concentration remains above the MIC. Different drugs, completely different rules of engagement.
All right, Section 4, the flaws in the formula, and our traditional blind spots.
So here comes the plot twist in our scientific narrative. As pharmacology has evolved, researchers have started to realize a harsh truth. Are these single snapshot indices really enough to guarantee success? The scary answer is, maybe not. The formulas we've sworn by since the 80s might actually be missing a massive part of the picture.
The fundamental flaw here is that these classic models check the bacterial head count exactly one time, usually at the 24-hour mark. It's just a snapshot, so they totally miss the dynamic, ongoing tug-of-war between the drug and the surviving bacteria. They miss resistance that might pop up late, like on day 3 or 4, and worst of all, they completely ignore wildly varying patient profiles. Like, if a critically ill patient has augmented renal clearance, their kidneys are flushing that drug out way faster than a healthy person. The old formulas just don't account for that.
A prime example of this blind spot is hypermutability. There was this fascinating study using an in vitro model where they pitted a wild-type bacterial strain against a hypermutable strain. On paper, they looked identical, sharing the exact same MIC of 1 milligram per liter. But under the exact same dosing regimen of meropenem, the hypermutable strain rapidly mutated and survived, totally outsmarting a dose that easily killed the wild type. Our old formulas utterly failed to predict this.
And then you've got heteroresistance. Think of this like a biological stealth mode. You test an isolate, and the vast majority of the bacteria look perfectly susceptible. But hiding in the shadows is this tiny, covert subpopulation of resistant cells. Traditional indices, which focus on the 24-hour bulk response, completely gloss over these hidden survivors. So what happens? They multiply, they take over, and cause a massive treatment failure when it's already too late.
Finally, Section 5, the future of dosing and model-informed precision.
So, if the old formulas are flawed and bacteria are basically evolutionary escape artists, constantly finding ways to mutate, how do we actually save lives moving forward? Well, the future is all about model-informed precision dosing. We are finally ditching the one-size-fits-all guesswork. Instead of leaning on a static MIC value, advanced mathematical models are pulling in dense genomic and microbiologic data. We're talking about tracking strain-specific resistance mechanisms and actually plugging in the patient's own immune response. It's no longer just about the drug and the bug, it is about this specific drug fighting this specific mutated bug inside this specific patient's unique body.
We've come a massively long way from the battlefields of World War II, where just having penicillin was a miracle. Now we're operating on the bleeding edge of personalized genomic modeling. But, the race against bacterial evolution is relentless. It never actually stops. So as we close this explainer, I want to leave you with this to think about. As our models get more and more sophisticated, how are we going to make sure these precision tools actually reach the patients who need them most before the next wave of resistance hits? Thanks for watching.